Okay, so we'll continue with our discussion on chest pain. So in the last episode, we discussed what are the organs in the chest, and they all can cause chest pain. We gave more importance to the cardiac cause of chest pain, mainly the general cause of chest pain. And I told you the flow, how the emergency medicine functions if the chest pain is a cardiac type of chest pain. So we should do an ECG. We should send biomarkers. If ECG is showing ST elevation, then we have to go for primary PCI as the first option, or we have to thrombolize and send them to a PCI enabled center, either for a secondary PCI or for rescue PCI. And the most important thing is we should give them a loading dose of 325 milligram of dispirin, 300 milligram clopidogrel, and 80 milligrams of atorvastatin. So since we started our discussion about ST elevation, we'll just discuss the basics of ECG in MI. We'll have a separate series on ECG later, but at present we'll just discuss in MI what all should you see. So as you know, the lead placement in ECG, right? So we have 12 leads. So the standard 12 lead ECG has 12 leads. It is 6 limb leads and 6 chest leads. I'm not going into the details. You will be aware of this now. So limb leads will be classified into 2, augmented leads and standard leads. So the standard limb leads will be lead 1, lead 2, and lead 3. Augmented leads will be AVR, AVL, and AVF. So these standard leads are bipolar leads. Bipolar leads is we are connecting 2 electrodes, so the difference between those 2 is measured. 6 chest leads are unipolar leads. So they are from V1, V2 to V6. So assume that this is the heart again. The sternum will be here. Okay, so this is the right side of the chest wall. This is the second rib. So I'll just tell you the chest lead placing. So if you have identified the second intercostal space, so angle of sternal angle will be here. The rib attached to that will be the second rib. Below that is the second intercostal space. So we are keeping the first lead, V1, first chest lead here in the right side. So to the left side of the chest wall, in the second intercostal space, we keep lead V2. So V4 is the mid-clavicular line, fourth intercostal space. So similarly, the same space, anterior axillary line will be V5, posterior mid-axillary line will be V6. V3 will be in between these two. Okay, so this is our chest. So as you can see now, V1 is in the right side of the heart. So V1 in changes correspond to the right side, right wall of the heart. Whereas V3, V4 and V5 are in the anterior wall. Mainly V3 and V4. V2, V3 and V4 are in the anterior part of the heart. So any changes in V2 to V4 mimic anterior wall changes. So V1 helps to find out right side of the heart changes. V2 to V4 is anterior wall. V5, V6 go laterally. So V5, V6 help to visualize the lateral wall of the heart. Okay, so understanding chest leads is easy. So V2 to V4 anterior wall, V1 right wall, V5, V6 is lateral wall. So the same diagram. Since I told you about the bipolar leads, they measure the difference between 2 places. Okay, so right upper limb, left upper limb, right lower limb, left lower limb. So we are supposed to keep 4 color leads there. Okay, so the mnemonic will be ride your green bike. So right upper limb will keep a red color lead, left upper limb will be yellow, left lower limb will be green, and right lower limb will be black. So I am telling this basically, suppose if you are stuck in a situation where you are supposed to keep the ECG lead, it is easy. You should, for chest lead, it is easy. You should just see the lead, keep in the corresponding space which I mentioned. For chest lead, see the color of the electrode and keep it in the corresponding lane. That's all. So what you have to remember here is, I'll draw a few vector diagram. We are not discussing the basics. I'm just telling you the easy way to remember. 0-degree angle corresponds to lead 1. Okay, so this will be the direction in which lead 1 will measure the electrical activity of the heart. Lead 2 will be 60-degree to this one. So this is lead 2. Lead 3 will be 120-degree. Okay, don't ask me how. This is how the vector will go. I'm just telling you in like a mnemonic. Okay, so this is how it corresponds to the heart. Lead 1 will be in this direction, 0-degree. Lead 2 is 60-degree. Lead 3 is 120-degree. You can see very well. Lead 2 is in line with the heart. Lead 2 is like the structure of the heart itself. That is the most important lead which we'll see in an ECG monitor. Continuous ECG monitoring in ICUs will be lead 2 because it is in line with the heart. Okay, so the lead 1, 2, 3 we have discussed. Now what about AVR, AVL and AVF? It is in between these two. It is in between. For example, 90-degree, between 60-degree and 90-degree, 60-degree and 120-degree, that is between lead 2 and lead 3. You have AVF, that is 90-degree axis. Similarly, lead 1 will be here. In between lead 3, that is the negative aspect of lead 3 and lead 1. So it is minus 30-degree will be lead AVL. We'll discuss about all this in some other time. Just remember the degrees at least now. AVR will be here, which is plus 210-degree. Right? The negative aspect of lead 1 will be 180-degree. It is above that, so 210. You can see very well, like lead 2 is 60-degree. It falls in line with the heart and its electrical axis. Lead AVR is opposite direction to that. So when all the leads are positive, AVR will be negative. Okay, so one of the criteria to say your ECG is normal is AVR should always be negative. Like all the way should be negative. P wave, QRS complex should be negative. T wave, everything will be negative in lead AVR. So here again you can see when we drew this diagram, lead 1 and AVL are in the lateral aspect of the heart, right? So we have already discussed V5, V6 also see the lateral wall of the heart. Lead 1 and AVL also see the lateral wall of the heart. So the inferior wall, you can see again, lead 2 sees the inferior, lead AVF sees the inferior, lead 2 sees the inferior. So lead 2, AVF and lead 3 see the inferior wall of the heart, right? So summarizing this in the form of a table, which wall is represented by which lead? So anterior wall, as we have discussed in the first diagram, lead V2, V3, V4. These are the chest leads. These 3 leads depict changes in the anterior wall of the heart. What about lateral? Among the chest leads, we have V5, V6. And among the limb leads, we have lead 1, AVL. So any changes in these 4 leads means there's a problem with the lateral wall of the heart. Now what about the inferior? Inferior wall, lead 2, lead AVF and lead 3. Lead 2, AVF and lead 3. So last discussion, we also told you about what mainly supplies the anterior wall of the heart. If you remember, it is the left anterior descending artery. So left anterior descending artery supplies the anterior wall of the heart. What supplies the lateral wall of the heart? It is mainly the left circumflex artery, LCX. What supplies the inferior? This we didn't discuss last time. I told you the right coronary artery supplies the right wall of the heart, and the same right coronary artery goes down and its distal part supplies the inferior wall of the heart. So it is the distal right coronary artery. There is a catch to it because some cases lateral circumflex artery also turns around and its distal part supplies the inferior wall. So again, it could be LCX. So if there are changes in the leads V2, V3, V4, it means there's a problem with the anterior wall of the heart. The vessel affected is left anterior descending artery. If there is a problem with leads V5, V6, lead 1 AVL, it means there's a problem with the lateral wall of the heart. The probable artery involved is left circumflex artery. If leads 2, AVF 3 are affected, it is called as inferior wall is affected. Probable arteries involved being distal RC and left circumflex artery. So this will give you an idea regarding the management. For example, so of course I'm teaching you to this because if you do a coronary angiogram, obviously everything will be visible there. But why doing an ECG and having an idea of the probable artery is important is the complications vary. For example, since anterior wall is the most important wall and the most common one, infarction of the anterior wall or anterior wall MI will cause failure as the most common symptom. Heart failure means patients will usually come with pulmonary edema. So your management of anterior wall MI, in addition to giving loading dose, thrombolysis, or PCI, should be in identifying or picking up pulmonary edema early. Plus, there can be severe ventricular arrhythmias as a complication. Because it is a larger part, so larger part is infected, more chance of arrhythmia. So we may have to give IV diuretics like furosemide. Similarly, we should restrict fluids in anterior wall MI. Don't give fluids liberally because the chance of pulmonary edema is more. Then we should watch for any arrhythmias, mainly ventricular arrhythmia. So we should always keep our defibrillator ready and monitor should always be running. Okay. The point why we are having a ICCU, coronary care unit, is to identify these arrhythmias in the first 48 hours. After 48 hours, that risk is reduced. So lateral wall is actually a small part. Only a left circumflex artery is affected. Not much of complications. Inferior wall is again important. It's like the opposite of left anterior descending artery. Because inferior wall, as I told you, it is mostly supplied by the right coronary artery. Right coronary artery also supplies the SA node. So if there is an inferior wall MI, what all you should think is there can be associated right ventricular wall MI, because whatever we told about the anterior wall, lateral wall is everything about the left ventricular walls. I told you the proximal right coronary artery supplies the right ventricle also. So right ventricular MI will behave differently. It is a right side of that. It's not the left side. So it doesn't cause pulmonary edema. Instead, it causes more of shock. So if inferior wall is affected, there's a chance that it could be right coronary artery. So right ventricular MI may be there. Patients usually can present with shock. So in inferior wall MI, we have to give IV fluids. It's the most important thing. So if there is a shock in left ventricular MI, we are not supposed to give fluids because they'll go for pulmonary edema. Like we discussed in the breathing difficulty chapter, we are supposed to give fluid restriction and IV diuretics. Whereas if it is an inferior wall myocardial infarction, chance of right ventricular MI is more chance of shock due to underfilling of the left ventricle. We are supposed to give IV fluids. So if you are thrombolizing a patient with an inferior wall MI in a low resource setting and we are planning for a referral, refer them with plenty of IV fluids. It is actually going to save the patient. Okay. So the second complication which is common with inferior wall MI is, as I told you, SA node is also supplied by right coronary artery. So they can go for heart blocks. So a patient can come with severe bradycardia. So a chest pain, patient is in severe bradycardia, think of right ventricular MI. So they may need temporary pacemaker. So remember, the cause of bradycardia is ischemia to the SA node. So doing thrombolysis, PCI, giving loading dose is going to support the same thing. But if rate is very low, causing hemodynamic compromise, we may have to give injection atropine, or sometimes it may need temporary pacemaker also. So in the peripheral setting or ICU, we can give atropine. Okay, so that is why inferior wall MI is important. So ECG is very important in MI because we are finding out that it is ST elevation. Second, we can localize what wall is involved, what artery is involved. We can predict the possible complications and we can decide on the additional management in addition to giving loading dose, thrombolysis, and referral for PCI. So till now we have been telling about elevation, right? So the first part which you should remember is what walls are represented by what leads. Now, what is meant by ST elevation? So just the revision of the basics. ECG will have the P wave. Next, we have the PR segment. QRS complex is normal. Then it becomes the ST segment. I mean T wave. The junction between the S wave and T is called ST segment. Then comes the next P wave. PP segment is called as isoelectric line. I'll draw the diagram now. TP segment is called as isoelectric line. I'll change the color so that you can follow. I'll draw the TP segment with the blue color. See, this is T wave. T wave is ending. The next P wave begins here. So the line joining T wave and the next P wave is called TP segment. Okay, so I have drawn a line that is the TP segment. It's called an isoelectric line. So with the red, I'll draw the next ECG wave. So P wave is here. QRS complex is here. Next ST segment comes here like this. I am slow in this part because it is a very important concept. Okay, so it comes like this. So you can see very well here the point where S wave ends. So this is Q wave, R wave, S wave. The point where S wave ends and becomes the ST segment, this point is called as the J point. Okay, just 1 millimeter. Like there'll be a small square in the ECG, just 1 millimeter or 2 millimeters away from that, we are supposed to measure the elevation. So here you can see it is the J point, the 1 millimeter after J point is just on the ST segment. So I'll draw one more picture so that you can see. Assume that this is the isoelectric line. P wave, QRS. So you can see that the J point is on the isoelectric line. It is not above that. Okay, so T wave, this is the P, Q. Here also it is just a small elevation is there. So when do you say is elevation? So 1 millimeter after the J point, above the isoelectric line, you have to measure how much elevation is there. So just see this diagram. P, Q, R, S. P wave is like this. So here clearly you can see there is elevation, right? So this is the TP segment. I'll draw that in blue. So this is the TP segment. So above the TP segment, J point is elevated to a few amounts. So you have to actually measure how many small boxes it covers. So probably assume that this has covered 4 small boxes vertically. So 4 millimeter elevation is actually ST elevation. So when do you say ST elevation is? In limb leads. So I already told you, for example, lead 2, lead 3, lead AVF. They see the inferior wall. So in the limb leads, if ST elevation is 1 millimeter. So where do you measure 1 millimeter? You have to find the J point where the ST segment, S wave ends or ST segment begins 1 millimeter after that. So if there is 1 millimeter ST elevation in limb leads, it suggests ST elevation. Whereas in chest leads, criteria is different based on the age. A little theoretical only, but males less than 40 years, if the limb lead elevation is, chest lead elevation is more than 2.5 millimeters. For males, more than 40 years, if the elevation is more than 2 millimeters. For females, if the elevation is more than 1.5 millimeters. Okay. So first step is draw the TP line in your ECG, identify the J point, go 1 millimeter lateral to the J point. That is the point where you have to measure. So see the ST segment height from there. In limb leads, if it is more than 1 millimeter, it is ST elevation. In chest leads, based on the age, if it is more than 2.5 millimeter in young males, more than 2 millimeter in elderly males, or more than 1.5 millimeter in females, it is ST elevation. I told you just some time back, if there is inferior wall MI, there is chance that right ventricular MI or posterior wall also could be involved in MI. So in addition to the standard 12 lead ECG, we have something called as right sided leads and posterior leads. So to a ECG technician, if there is inferior wall MI, you should instruct them to see the right sided leads and posterior leads also. For posterior leads, the criteria for ST elevation will be 0.5 millimeters. Okay, so if you go to the internet, you can just put ST elevation, you'll get so many ECGs. Just think in mind and look at these criteria, you'll understand it, right? So the entire point of discussing the ECG, discussing the walls and discussing about ST elevation is treatment for ST elevation is emergency primary PCI, which is the definite treatment. If it is not possible, you have to thrombolize them with either streptokinase, altiplase, retiplase, or tenecteplase and refer them for pharmacoinvasive approach for secondary PCI or rescue PCI if there is a failed thrombolysis. So when do you say failed thrombolysis? 50% of the ST segment height should reduce after 2 hours. If it is not there and pain is also still persistent, it is called as failed thrombolysis. You have to refer them for second. Suppose, coming back to our initial discussion where we started about acute coronary syndrome, STEMI and InSTEMI. Patient is having elevation of the markers, but ST segment is not elevated. So patient is having any ECG abnormality other than ST elevation. So it could be an ST depression. So ST depression is ST segment is below the isoelectric line. So if there is ST depression, if there is a tall T wave, okay, if there is a T wave inversion, if there is any ECG change in ST segment or in the T wave other than ST elevation, then we can call it as non-ST segment elevation. So unstable angina, already I told you, patient is having pain at rest, crescendo type of pain, but there is no ECG changes and no markers. Then it is called unstable angina. Because unstable angina, it may not be necessary to do a procedure or angio electively or even as an emergency. It's enough to give them injection heparin. And the antiplatelets, aspirin, clopidogrel, atorvastatin. Whereas, so what dose of heparin usually for dollars? Different books say different things. So injection heparin 5,000 units, IV Q630. If you are giving it subcutaneously, there will be a slow release. So subcutaneously, we can give it test Q830. This will be the dose, injection heparin. Now we have something called a slow molecular weight heparin, enoxaparin. So it comes as 0.4 ml or 40 milligram. So again, based on the weight, 40 kg person, we can give 40 milligram. Subcutaneous BD will be the dose. So this is enough for unstable angina. If it is a non-ST segment elevation MI, then I already discussed the same thing. Same loading dose. We are going to continue that with antiplatelets and atorvastatin, and we can give injection heparin or low molecular weight. But we have to plan for coronary angiogram, but it is not emergency basis. May be planned in an elective basis. In NSTEMI, we can go for angio earlier or PCA earlier if pain is still continuing despite giving the initial management. Why thrombolysis is contraindicated in NSTEMI? Because the clot formed in NSTEMI is a different type of clot than formed in STEMI. NSTEMI will have an unstable clot. So if you are thrombolizing, the clot can break down easily and it can embolize to other areas and even cause stroke. So that is why if it is a STEMI, we can go for thrombolysis if not going for PCI. If NSTEMI, we are not going to thrombolyze, the ideal option is PCI, but based on the situation, either emergency PCI or a non-emergency PCI, we can give heparin initial. So this is the entire idea of the myocardial infarction. So we'll resume our discussion on other causes of chest pain. So I was telling you in cardiac causes of chest pain, one will be anginal chest pain, other one is non-anginal chest pain. So one cause of non-anginal chest pain will be pericarditis. Remember, pericardium and pleura and both are the coverings of the heart. So when there is a pericarditis, there will be pain in the place where pericardium is present. So pericardial pain also will be retrosternal. Okay, pericardial pain also will be retrosternal. It will be like it will be a sharp pain or lancinating pain or stabbing pain. கத்தி எடுத்து குத்துற மாதிரி இருக்கும்னு சொல்லுவாங்க. So it will be a lancinating pain. So pain will be less when it is in contact with some surface. So pain is relieved on leaning forward. So on leaning forward, the pericardium comes in contact with the chest wall. It reduces the movement of the pericardium. So there will be less pain. Similarly, so we'll discuss a side note also about pleuritic type of chest pain. So as I already told you, another organ in the chest will be lungs and its covering called as pleura. Lungs are pain insensitive structure. So any lesion of the lung will not cause pain by itself. Okay, so a pneumonia will not cause chest pain. A hemoptysis will not be having chest pain. But when there is a pain in a lung disease, remember associated pleura syndrome. So when pleura is the covering of the lung, so what's the characteristic features of pleural chest pain? So like we discussed about anginal chest pain, so pleuritic chest pain, the characteristics are, one, it is usually in the lateral aspect of the chest or axilla. Why axilla? The two layers of the pleura, parietal pleura and the visceral pleura, are in close proximity in the lateral aspect of the chest. So pain is more in the axilla. As I told you, it is a lancinating or stabbing type of pain. It will be a severe. So what aggravates the pain is deep breathing or movement. Like if they turn around in bed, pleura will rub against each other, there will be pain. So what relieves the pain is, like in pericarditis. Pericarditis, when they lean forward, pericardium comes in contact with the chest wall. In pleuritis, when they lie to the side of the lesion, the chest wall comes in contact with the bed. So it's called as auto-splinting. This will reduce the pain. Okay, so pleuritic pain and pericardium. Sometimes pleura and pericardium both may be involved together in some diseases, pleuropericarditis. Okay, so this is the characteristic features of pleuritic pain. So remember we discussed in anginal type of chest pain, pain in the retrosternal aspect, compressing type of chest pain, pain aggravated on exertion, relieved on rest will be anginal pain. Whereas pleuritic pain will be mostly in the axillary region, stabbing type of pain, more on deep breathing, and pain will be relieved on lying to the side. Many of the cases in secondary care centers, we get referrals from small hospitals telling that suspected MI, minor ECG changes. Okay, so most of the time, those pain will be just a pleuritic type of chest pain. Okay, patient will be having a pneumonia. Patient may be having, so the causes of pleuritic pain will be pneumonia, pneumothorax, pulmonary embolism. When pulmonary embolism is there, blood supply to a part of the lungs get affected. So they go for infarct. When they go for infarct, they irritate the nearby pleura. So pulmonary embolism causes pleuritic chest pain in the later part of its course. So people don't pick up the other features. Just by chest pain, they do an ECG. There may be some minor abnormalities like a T-way inversion or a mild ST elevation not satisfying the criteria. They refer immediately to a higher center even without anything, telling that it is a MI. So that may not be ideal in situation. So if you are very clear about the ECG finding, what to specifically look for, whether it is an anginal or a non-anginal type of chest pain, we can reduce that stress among yourself and to the patient. Right? So that's nothing much to discuss about pleuritic chest pain, because treating pleuritic chest pain is just supportive. Give only painkillers, ask them to lie to the side of the lesion, treat the underlying etiology. Okay, pneumonia, treating with antibiotics. Pneumothorax we discussed last time, needle thoracocentesis or ICD. Pulmonary embolism, there's a clot. So here again, treatment will be injection heparin, but the dose will be different. So we may have to give infusion of heparin for the first 48 hours. Like example, it will be 1000 units per hour infusion for the first 48 hours. Then we'll make it again injection heparin 5000 units IV Q6 thoroughly. Okay. One side note is heparin is usually preferred in cases when CKD is there. Low molecular weight heparin is preferred when CKD is not there. Just a side note. So we have finished pleuritic chest pain completely. So similarly, pericarditis. Pericarditis means pericardium is involved. So this cases may need echo. So echo, we have to find out whether fluid is there or not. So if fluid is there, then the evaluation will go in a different direction. Pericarditis usually won't be that life-threatening. So pericarditis also will have ECG changes. So there will be ST elevation in all the leads except AVR. So I told you initially, AVR will always be opposite to the other leads. So there will be ST elevation in all the leads except AVR. Whereas in myocardial infarction, we'll make a table to differentiate. Whereas in myocardial infarction, there'll be only a based on the wall, based on the vessel involved, there'll be changes. Only in selective leads will be there. Plus, when particular lead is showing an elevation, in MI, the opposite lead will show depression. For example, if anterior wall there is elevation, inferior wall will show depression. That is called as reciprocal change. So in MI, vessel-based ST elevation will be there. There will be reciprocal ST depression in the opposite leads. Whereas this feature will not be there. So there will be no reciprocal changes. All the leads will show elevation. Right. So there are other features also. We will not discuss that. So if the patient is showing non-anginal pericarditic type of chest pain, again, as discussed first, ECG should be done in every case of chest pain and abdominal pain. So if there is ST elevation in every lead, there is no reciprocal change. It probably would be pericarditis. Refer them to the higher center for echo. Like if there is pericardial effusion, if there is pericardial inflammation, that's separate evaluation to that. Whether it is infective, tubercular, toxic, post-MI, there are many causes. So similarly, nothing much in pleuritis, we have discussed that. So chest is done, heart, blood vessels and pericardium is done, lungs is done. Then only two more are there, esophagus. Many a time, esophageal pain will look similar to MI because esophagus is directly behind the heart. That is one. Second, esophageal pain usually will be a cramping type of pain. There may be some relation to food intake. Okay, so there are many examples. For example, GERD, the acid in the stomach may come above and irritate the esophagus. So mostly there'll be some relation to food. There'll be pain on taking the food. There'll be pain on lying down. That is the most important thing, because on lying down, what happens is the acid from the stomach comes up and irritates the esophagus. So chest pain, more in the night, more after food intake. This will be a burning type of pain. Okay, so burning type, retrosternal, pain more on lying, relieved after sitting up or maybe after drinking water. All this are features of GERD. So as since I told you, this is also retrosternal. Sometimes it can cause cramping type of pain. There are two aspects to it. Many people think MI pain to be a cramping pain. So they dismiss their myocardial infarction pain to be a gastritic pain. And some people consider their gastritic pain and come to the doctor and considering it to be a MI pain. So whatever it is, whatever pain, ask them to go to the hospital, because we don't know who is having what. But to you, if ECG is normal, okay, and pain is more of burning, like other GA symptoms are there, it could be esophagitis. So if history is very typical, it is enough if you give them supportive management. For example, syrup sucralfate. You can give them proton pump inhibitors like pantoprazole, omeprazole. Pain won't come down immediately. It may take 2 or 3 days for the ulcer to heal. So another category where esophageal pain can occur is esophageal motility disorders. For example, there's something called DES, diffuse esophageal spasm. So here there won't be burning type of pain. It will be like a retrosternal cramping type of pain. Sometimes the cramping can be severe so as to cause sweating. So again, ECG only help to differentiate between these two. Okay, so that's all about esophageal pain. And many people come to you. I did an exercise last week. From that, my left side of the chest is having a continuous pain. This will be the symptom which most people come with. So always remember, whenever there is a continuous pain, okay, continuous pain, more with movement. So understand the terminology everywhere. Cardiac chest pain increases with exertion. It's not just movement. Pleuritic chest pain increases with movement and on deep breathing. Whereas pain present more on moving. Like when they move, their vertebral column moves, rib moves. So pain more on movement, relieved on just sitting, will be mostly a musculoskeletal type of pain. So musculoskeletal means problem with the vertebral column or the ribs or the bones. Some trauma may be there. So this is given a book called Fishman's Pulmonology. Okay, so when pain is present continuously without any danger signs, it is usually musculoskeletal. So to you, as I already discussed last time, you are whether the chest pain is life-threatening, potentially life-threatening, or a non-life-threatening condition. So the potentially life-threatening conditions are, as I discussed, MI and those things. So this is a non-life-threatening condition. So this should be our last priority to rule out. So always do an ECG, chest X-ray, maybe if possible echo and cardiac biomarkers in any chest pain. So this is about musculoskeletal pain. And musculoskeletal also includes the local skin. So sometimes patient may be having continuous pain. We'll be doing everything, but we will fail to look at the skin of the chest. Patients may have herpes zoster as their cause of pain. Okay, so that is why the first discussion I told you. Whenever there's a pain, think of the possible structure which is causing it. Okay, whether it is heart, pericardium, the lungs or the pleura, the esophagus or the chest wall. Chest wall includes the skin also. Okay. So last 1 minute, I forgot to tell about the cardiac biomarkers. So I told you TROP-I should be sent in cases of CKD. TROP-T is preferred than CPK-MB because CPK-MB starts to rise only after 12 hours maybe, whereas TROP-T starts to rise in 6 hours. So even if the first ECG or the first cardiac biomarker is normal, you should never stop with that. If you are having a doubt, you should repeat them frequently because the second ECG or the second TROP-T may be positive. Okay, and TROP-T will remain to be positive for maybe up to 3 to 4 days, where CPK-MB settles in 1 to 2 days. Right? Okay, so summarizing this chest pain, we have discussed the 4 organs causing it. We have discussed about MI in detail and the other causes, important features, how to differentiate internal causes. One thing which we didn't discuss is about aortic dissection. It causes abdominal pain more than a chest